Good day and welcome to our lecture series. I am Dr. Teke Apalata, a consultant in clinical microbiology. We are now going to start discussing streptococcal infections. So this lecture series will be done in 4 parts, and we will discuss all different types of infections that are caused by streptococca. So let's start with this first part, and in this first part we will mainly focus on pharyngitis. We will look at pharyngitis, scarlet fever, skin and soft tissue infections that are all caused by streptococca. So let's look at different species of streptococca. We have what we call a hemolytic streptococca, and those are mainly beta hemolytic and alpha hemolytic streptococcus. And we have, so mainly the beta hemolytic are mainly group A, group B, group C, and group G streptococca. And the alpha hemolytic are mainly group D streptococca. So the group A Streptococca is also what we call a Streptococca pyogenes. Group B is called the Streptococca galaxiae. Group C and group G, they are just called C Streptococca and G Streptococca. And we have one here, alpha Streptococca, that is mainly Streptococca pneumoniae. And we have group D that is not an Anthracoccus, but it's called a non-anthracoccal group D streptococca, that is Streptococca bovis. And beside those hemolytic streptococca, we have also another group that we call oral streptococca, that are mainly alpha hemolytic streptococca. And these oral streptococca, they were called initially viridans and viridans streptococca, and they are mainly cause oral cavity or endocarditis infections. So we have Streptococcus salivarius, sanguis, mutans, and mitis. And we have Streptococcus aeruginosus, constellatus, and intermedius that are together called the Streptococca miliary group. And the last one category is what we call Anthracoccus, and we have mainly Anthracoccus faecalis and Anthracoccus faecium. So those are the types of species, different species of Streptococca that are causing infection in humans. Now let's look at Streptococca pyogenes, or group A Streptococca. Streptococca pyogenes is quite a well-equipped microorganism in terms of virulent factors. It has a lot of extracellular toxins and enzymes. So we have it has what we call streptolysine O and streptolysine S. Those, they are able to destroy membrane of erythrocytes and other cells in our body and help in depicting, and they can also use for diagnostic purposes. So when we measure, for example, anti-streptolysine titers, it will help us to try to suspect a past streptococcal infections. But they are also virulent factors, so they play a role in destroying our human cells, and so that you can develop a streptococcal infection, especially soft tissue infections. We also have what we call pyrogenic streptococcal exotoxins. Pyrogenic streptococcal, those are super antigens, and when they are released, they induce large amounts of cytokines. So they are then responsible for fever, scarlet fever, exanthema that we can see, and sepsis and septic shock. So the patient will develop sepsis and leading to septic shock because of pyrogenic streptococcal exotoxins. The Streptococca pyogenes also have a streptokinase. They are able to dissolve fibrin and facilitate the spread of Streptococca within the tissue. So they can, that's why they are involved in much more serious infections that we will see. And they also have a hyaluronidase that breaks down a substance that cement tissue together. They break it down. They also have DNAs that break down the DNA and producing granipas. So the Streptococca, then they have all these virulent factors. They are able to invade the skin and the mucosa of the host. They can cause localized infections, but they can also lead to generalized invasive infections, as we see, leading to sepsis, septic shock, and a much more serious infection that we call a necrotizing fasciitis that we will see. And among localized infection, we have impetigo, we have Erysipelas, we have cellulitis, we have lymphangitis, we have sinusitis, otitis media, and tonsillitis. And we also have another condition that is associated with pharyngitis and tonsillitis. It's called the scarlet fever. So we will look at that. So look at group A streptococcal suppurative infections. The first one, we have pharyngitis, and what is scarlet fever is associated with pharyngitis, especially with a strain of streptococca that are able to cause pharyngitis. So group A streptococca are the most common bacterial cause of pharyngitis, and primarily it affects school-age children between the age of 5 and 15 years. And then the disease spread, the organism spread under crowded conditions, such as schools and military facilities. So pharyngitis and its association with rheumatic fever are seasonal. So it's mainly this infection, this pharyngitis, mainly happen during winter area. It affects mainly school-age going children. Then after that, they will develop what we call rheumatic fever as a complication. And then I also say that scarlet fever is also associated with those strains of streptococca that are causing pharyngitis. And to make the diagnosis of scarlet fever, you mainly need 3 things. The patient will present with a red rash. That is, the rash looks like a sunburn, and it starts with the face and the neck and going down the trunk, the arms, and the leg. So it's what we call a red rash. And the patient will also present with a flushed face. So the face may appear flushed with a pale ring around the mouth. And they also have what we call a strawberry tongue. So the tongue generally looks red and bumpy. So we call it a strawberry tongue. So if you see a patient with a red rash, a flushed face, and a strawberry tongue, then you can make the diagnosis of scarlet fever. Other signs may not or may be there, like fever and pharyngitis can be there, or it can come after that. So this is what you see. You can see the red rash starting from the face, and it can go down to the trunk and the limbs. And here you have a flashy face, you know, with a pale ring around the face. And here you have a strawberry tongue. So those are together helping you to make the diagnosis of scarlet fever, And you can also see other patients developing what we call erythema marginatum. Erythema marginatum, what you can see here. So it's actually the presence of pink rings on the trunk, or you can see here on the limbs. This is how it looks like in someone with a light skin. And here, this is what you see in someone with a dark skin. That's what you can see. So this is called erythema marginatum, and it's associated with streptococcal infection. Then we also have what we call pyoderma or pyoderma, and streptococcal skin infection that can be cellulitis or erysipelas. So Group A Streptococca, but those are now different serotypes from the serotypes that cause pharyngitis. Pharyngitis that is associated with scarlet fever, with rheumatic fever, or with other conditions that we discussed. But those serotypes of group A Streptococca are associated with cellulitis and erysipelas. So they are different from those that are causing pharyngitis. And the reason it is important is because these serotypes are associated as a complication, they are associated with what we call post-streptococcal glomerulonephritis. So people who present glomerulonephritis as a result of a previous streptococcal infection, if you look at in their clinical, in the history, you will find that they had skin and soft tissue infection, you know, like impetigo, like cellulitis. But those who develop rheumatic fever, those one, if you look at in the history, you will see that they had pharyngitis. So those are different strands and they are associated with different complications. This is Erysipelas. So Erysipelas is a distinctive form of cellulitis with a characteristically raised and erythematous superficial layers of the skin. In contrast, through cellulitis, they actually progress toward affecting subcutaneous tissue, but erysipelas is much more superficial. You know, that's what you see in these patients. Now, streptococcal pyogenes can also cause other complications, much more invasive streptococcal disease like streptococcal toxic shock syndrome or necrotizing fasciitis that will lead to septicemia and septic shock. And this is a patient with a necrotizing fasciitis, and you will see that there is a massive destruction of the patient tissue. And as a result of those different virulent factors that we have discussed, and these might lead into an amputation, you know, just a delay in the management of few hours, you will see that a serious progression of these conditions. So what is the pathogenesis? The pathogenesis involves mainly a number of virulent factors that we have spoken about, mainly the pyrogenic, exotoxin, and super antigens that we have said. We have extracellular pyrogenic exotoxin A, B, and C, and super antigens such as exotoxin F and the streptococcal super antigen. So they are mainly involved in those invasive conditions like necrotizing fasciitis, so they are able to destroy the tissue. So what happens is that those super antigen will interact with the MC class 2 molecule and will then liberate a large amount of inflammatory cytokines. So there is a very strong inflammatory response that will then destroy tissues and lead to with the release of cytokines such as tumor necrosis factors and interferon gamma. And because they are released in excess, they will cause tissue destruction. Other virulent factors like pyrogenic exotoxin B, those are extracellular cysteine protease, which has shown to cleave fibronectin and fibronectin extracellular matrix proteins. So they are able to create destruction of the tissue. We also have humans with a diverse range of invasive disease like erysipelas, cellulitis, pneumonia, bacteremia, septic shock, all produce elevated levels of antibodies against streptococcal pyrogenic exotoxin B. Following the infection, we have also the effect of the M protein serotypes. Now, the treatment of this invasive condition actually involve firstly the antibiotic therapy. But the antibiotic therapy is not always effective, and the mortality has been shown if you use antibiotic alone, 50% of those patients will die. And the penicillin, that is usually susceptible against streptococcal group A has been shown to fail in this situation. So the failure of penicillin to treat those severe invasive cases could be attributed to the phenomenon that a large inoculum reaches the stationary phase quickly, and penicillin is not very effective against slow-growing bacteria, and the treatment will not work. So studies have shown that clindamycin in experimental models of fulminant infections appear to be much more effective than penicillin. In addition to antibiotics, you need to give intravenous immunoglobulin. So we give immunoglobulin, IV immunoglobulin, and the reason for this may be that immunoglobulin provide a neutralizing or protective antibody effect to the patient. And you can also give anti-M1 antibodies and combine with super antigen neutralizing antibodies, and in the IV immunoglobulin should contribute in reducing mortality rather than relying on antibiotic alone. So then you will manage that. Then you manage septic shock. So give fluid, you resuscitate, you put patient on vasopressors, and you also monitor lactate level from the serum. And you extensively do surgical debridement. You take this patient often in theater for surgical debridement. So this is the first part of this lecture on streptococcal infections, and follow our second part of the lecture on streptococcal infection to understand what we have to offer. Thank you very much. Bye.